Hello everyone, we will talk about the bird shock in surgery. Part 1. Understanding of bird shock. Part 2. Pathogenesis and harm of bird shock. Part 3. Prevention and treatment measures of bird shock. Part 4. Dynamics of bird shock prevention and treatment. First, let's talk about Part 1. Understanding of bird shock. Bird shock can be life-threatening, and it's important to conduct the fluid therapy in time. It is not smooth to get through the bird shock period, which is often due to delayed liquid infusion, long-distance transfer, or failure to solve the airway patency problems, long-term tissue ischemia and hypoxia, and proneness to infection, and damage to multiple internal organs, thus affecting the stable course of disease and the success of treatment. Fluid resuscitation is the main measure to treat bird shock. In the past 20 years, with the improvement of the level of resuscitation during shock period, the number of people directly dying from shock has decreased significantly. But the problems caused by shock are still far from being resolved. There are still many problems in bird shock. Delayed resuscitation occurs due to delay in intervention. It is not smooth to get through the shock period due to non-standard intervention. It is more difficult in late treatment for patients with bird shock, with more complications and high case fatality rate. Therefore, bird shock is still the first difficulty in the treatment of severe burn patients. Prevention and treatment of bird shock is still one of the primary tasks of severe burn treatment. Part 2. Pathogenesis and harm of bird shock. Pathogenesis of bird shock. Bird shock is mainly caused by hypovolemia, cardiac function decline, and compound injury, including hemorrhagic shock and shock caused by pain, hypothermia, and other factors. For hypovolemic shock, 1. Capillary permeability changes are the root cause. The decrease in osmotic pressure in blood vessels exacerbates the extravasation of plasma components. Large ions and waters are lost simultaneously. On the one hand, sodium ion and water penetrate tissue gaps and wounds. On the other hand, the cell membrane is injured due to hypoxia. The activities of sodium, potassium, and ATPase on the cell membrane are significantly reduced, resulting in influx of sodium ion into the cell. The water in the extracellular fluid also flows in the cell while influx of sodium ions. Massive evaporation of wounds promotes further reduction of blood volume. Harm of shock and mechanism thereof. Injury effects on organs, ischemia and hypoxia, and any factors that affect the tissue oxygen supply can lead to dysfunction, injury, and eventual death of cells, resulting in insufficiency or failure of organs. Further, prolonged hypodynamic circulation of stasis and microthrombolysis caused by the delayed bird shock induce accumulation and activation of platelets. Pre-excitation of leukocytes and the accumulation. Chemotaxis and the invasion of their hypoxic part cause the in-tissue edema of tissue cells and increased capillary permeability, resulting in further damage to the affecting organs through a series of chain reactions. Oxygen-free radical injury. The energy reserves of tissue cells are consumed a lot, and the ATP, the main energy carrier, is decreased a lot under the condition of organ ischemia. thus generating hypoxanthine. When the tissue hemoperfusion is restored, hypoxanthine is catalyzed by xanthine oxidase to eventually produce uric acid and a large amount of oxygen-free radical under the aerobic condition. In addition to extensive oxidative injury to tissue cells through a unique chain reaction, oxygen-free radical may further induce apoptosis of organs such as heart, liver, and intestinal mucosa, causing structural and functional injury to organs. Second, the susceptibility of infection to the body is increased, which is mainly caused by the following three reasons. Tissue edema. Shock can exacerbate tissue edema in different degrees, thus increasing the incidence of acute infection by edema during the resorption period. Intestinal mucosal injury. Free radical injury of intestinal ischemial reperfusion can cause intestinal bacterial translocation and intestinal infection. Immunosuppression. Delayed resuscitation can exacerbate the suppression of phagocytosis of macrophages and neutrophils. After antigen presentation of macrophage, inhibited proliferation of lymphocytes and reduced the ratio of T helper cells and T suppressor cells, resulting in immunosuppression. This is the main reason why delayed resuscitation increases the risk of infection. Prevention and treatment of burn shock. The common liquid formula is based on that total of 1.5 ml of colloid, and electrolyte fluid shall be supplemented per kilogram of body weight for every 1% of the burn area, including partial thickness burns and full thickness burns of an adult in the first 24 hours, according to the Third Military Medical University. The ratio of colloid and angelite fluid is 1:2. The ratio for patients with extensive deep burns and children burns can be changed to 1:1. In addition, 5% glucose solution shall be added to replenish water, which is 2,000 ml per day for adults, and concentrated for children according to age and weight. Half of the total shall be infused in the first 8 hours, and the other half shall be infused in the next 16 hours. Rapid infusion is required for patients with large area of burns and severe symptoms, but shall be avoided for patients with original cardiopulmonary insufficiencies so as not to cause heart failure and pulmonary edema. In addition to the same base water content, the total volume of infusion of colloid and electrolyte to the second 24 hours is half of that in the first 24 hours. Intravenous liquid infusion can be reduced on the third day, or only oral liquid infusion can be used to maintain body fluid balance. It is appropriate not to infuse the hypertonic glucose saline too fast for infusion with sodium bicarbonate for severe patients. The preferred crystalloid solution is balanced salt solution, which can avoid hyperchloramine and correct partial acidosis. Second, isotonic saline and 5% glucose saline can be used. The preferred colloid fluid is plasma to supplement the most plasma proteins. If patients cannot afford, dextrin and phenylalanine can be used as a temporary substitute. As whole blood contains red blood cells, It's not suitable for hemoconcentration after burns, but it is suitable for deep burns that injure a large amount of red blood cells. Patients with extensive deep burns are often accompanied by severe acidosis and hemoglobinuria, and avoid accumulation of hemoglobin degradation products in the renal tubules. 1.25% sodium bicarbonate can be added to the infusion to correct acidosis. Currently, the existing problems in the prevention and treatment of shock include the following. 1. Some people resist the infusion volume. Help patients to get through the shock period at low standard. Mechanically applied the resuscitation formula of shock period formulated in 1970, and dare not exceed the calculated volume from the formula. They have doubt on liquid infusion during shock period. Infuse less rather than more. Think that it's a successful anti-shock as long as getting through 48 hours. And are afraid that more liquid than the calculated volume may exacerbate the edema and resorption, even induce cerebral edema, pulmonary edema, and other complications. Although the patients with restricted infusion has got through the shock period, they could not get satisfactory resuscitation, laying the cause of ruin for the late complications. 2. Keep to conservation to give rapid and large amount of liquid infusion for patients with delayed resuscitation, and infuse liquid according to the conservation formula and velocity. Some physicians do not understand that the golden time for early resuscitation have been lost when patients are admitted to the hospital. If they are not infused rapidly unconventionally within 2 or 3 hours after admission, it will not be enough to correct the hypoxia damage caused by hypovolemia, making it more difficult to treat the patient with delayed resuscitation. Some people are lack of experience, don't understand the quality and quantity of infusion. One-sidedly think that the treatment during shock period is mainly liquid infusion, but don't know how much and what to infuse, and how to attach importance to infusion volume. Neglect the infusion compounds, and even do not know the contents and significance of shock and the comprehensive treatment. At the present, the PLA Burn Research Institute, a first affiliated hospital of the Chinese PLA General Hospital, has proposed 3 goals for prevention and treatment during the shock period, to guide shock treatment and improve the quality of treatment. It mainly includes the following 3 points. 1. Rapid and sufficient fluid resuscitation. 2. Rapid recovery of intestinal blood supply. 3. Prevention and treatment of reperfusion injury. The first goal is rapid and sufficient fluid resuscitation, including sufficient liquid infusion volume, proper liquid infusion components, and suitable liquid infusion velocity. As for the calculation of liquid infusion volume, a large number of clinical practice shows that the previous infusion formula cannot guide the fluid resuscitation in patients with the severe burns, and a new infusion formula reference is urgently needed. At present, we have conducted hemodynamic monitoring on 52 patients with large area burns using swollen catheter. The liquid infusion volume is adjusted from time to time to achieve normal hemodynamic indicator according to the changes of hemodynamics. And then the formula of liquid infusion is calculated according to the liquid infusion volume at this time, which is of great clinical reference value. 304 infusion formula. The infusion volume in the first 24 hours, 1.8 to 2.0 milliliter. Crystalline and colloid, kilogram. Body weight, crystalline and colloid, kilogram body weight. 1% area. 3,000 to 3,500 milliliters, 5% glucose solution. The infusion volume in the second 24 hours, 1.5 milliliter. Crystalline and colloid per kilogram. Body weight per 1% area. 3,000 millimeter, 5% glucose. Liquid infusion components. 1. Colloid solution. Plasma. Because the main component of exudate is plasma, it is ideal to infuse plasma after burns. Albumin. The colloid osmotic pressure is mainly maintained by albumin, and the albumin content in the exudate is equivalent to 90% of the plasma albumin concentration. Therefore, it is essential to infuse albumin for maintaining colloid osmotic pressure. The albumin diluted to 6% is applied clinically. Its concentration is higher than plasma, which is beneficial to improve colloid osmotic pressure and reduce edema. Daily infusion of 10 gram albumin can absorb 200 milliliter water and increase 200 milliliter of plasma volume in 45 minutes. Dextran. Dextran is one of the common plasma volume expanders. It is a polymer of glucose and can increase the colloid osmotic pressure after infusion. The application of low molecular dextran and small molecular dextran can not only maintain circulating blood volume, but also reduce blood viscosity, release erythrocyte aggregation, improve the microcirculation, and have a diuretical effect. Because of low molecular weight of small molecular dextran, it can only maintain blood pressure for about 3 days. By contrast, low molecular dextran is better. 1,000 to 1,500 milliliter is used throughout the day. Pelagialine. Pelagialine is a modified liquid gelatin-based colloidal plasma substitute. Its molecular weight is 22,500 Dalton. It has isotonic pressure and pH value similar to plasma. The colloid osmotic pressure is equivalent to that of human serum albumin, and the blood volume effect is equivalent to 4 to 4.5 human serum albumin solution. The biologic half-life is about 4 hours, which can maintain blood volume well. The daily refusion can be adjusted flexible based on the demand of colloids and the supply of blood products. 1,000 to 3,000 millimeter per 24 hours. In overall evaluation, pelagialine is a better plasma substitute, which is preferred when blood products are insufficient. The crystalloid solution contains normal saline, which is isotonic sodium chloride. It is also one of the common electrolyte solutions. In fact, normal saline is not completely physiological. The concentration of sodium chloride in normal saline is 0.9%, which contains 154 millimole per liter of sodium ions and chloride ions, while the concentration of sodium ion in plasma is about 140 millimole per liter, and that of chloride ions is 103 millimole per liter. If a large amount of normal saline is infused, The proportion of chloride ions will increase in the plasma, and the proportion of bicarbonate radical will decrease, which will lead to hyperchloric acidosis. Therefore, 1.25% sodium bicarbonate solution shall be infused into a ratio of 2 to 1. In case of fusion of a large amount of normal saline to avoid the adverse reaction of normal saline, lactated Rayner's solution, commonly known as the equilibrium liquid, contains 130 mmol per liter sodium ions and 109 mmol per liter chloride ions are similar to that in plasma and will not cause hyperchloric acidosis, but sodium ions are lower than that in plasma. Other components include diuretic and alkali drugs. Liquid infusion velocity. As for the conventional liquid infusion volume and time distribution, the conventional liquid infusion and time has been mentioned above. In case of delayed resuscitation, the liquid infusion volume and time distribution shall break the limitation of the infusion formula to create the effective hypovolemia in the shortest possible time. Generally, 1,500 to 3,000 ml of liquid shall be injected within 30 to 60 minutes, and then infused by intravenous drip. When the initial resuscitation time is 6 hours or more after burn, it's often necessary to make up half of the first 24 hours planned infusion volume within 2 to 3 hours. Indicators of satisfactory fluid resuscitation, including clear consciousness, heart rate at 100 to 110 beats per minute, 20 to 24 breaths per minute, normal blood pressure, urine volume 18 mm per hour, hemoglobin less than 115 gram per liter, hematocrit less than 0.5, with no apparent electrolyte disturbance. Several issues to be noted in fluid resuscitation. 1. Individual adjustment. Fluid loss often varies greatly with different burn depths, whether it is accompanied by inhalation injury, and the demand for fluid is also difficult if so. Treatment before admission differs in thousands of ways, and there are also differences in the health status of the wounds before burn and the response to liquid infusion. Therefore, we need to adjust from time to time according to the clinical manifestation of each patient. The second goal is rapid recovery of intestinal blood supply. Decreased blood volume leads to insufficiency of tissue hyperperfusion. The intestinal tract is sensitive to ischemia, where the ischemia occurs earlier, but is latest to recover. The conventional liquid infusion cannot be corrected. Generally, anisotomy shall be administered by intravenous drip at the same time of liquid infusion. The third goal is the prevention and treatment of reperfusion injury. Oxygen-free radical scavengers and antioxidants are added. In addition to mannitol, common drugs also include vitamin C, 10 grams per day for adults. Adjuvant therapy during shock period include maintenance of cardiac function and respiratory function. Use of antibiotics for patients with delayed resuscitation. The level of antibiotic use shall be increased appropriately on the basis of strengthening bacteriologic investigating and immunity-enhancing drugs. such as gamma globulin gymnasium, shall be used as early as possible. Application of sedatives. It is considered that irritability during shock period is caused by hypovolemia. So sedatives shall be used with caution to avoid the symptoms of shock covered up by the jaw. For the wounded with severe and unbearable pain, half of the mixture of duloxetine and Ferrigan by intramuscular injection or intravenous perfusion can be selected. Application hormone. Hormone therapy is generally not required due to the adrenal cortical hyperfunction in the early stage of burns. If the early resuscitation of critically ill patients is not good, a shock of 15 to 100 mg of dexamethasone can be given when the urine volume is not increased after the body volume is made up upon admission, followed by rapid infusion of 100 mg furosemide. The diuretic effect is better. Dexamethasone shall also be given before diuresis in case of overload of fluid intake or complication of pulmonary edema. Early feeding. The previous habit of no eating in the shock period shall be broken, and gastrointestinal feeding shall be started 6 to 8 hours after injury under the premise of good resuscitation. The advantages include 1. It is helpful to stimulate the secretion of gastrointestinal hormones such as gastrin and mortallin, which may promote intestinal peristalsis and help digestion. 2. It protects the gastrin mucosa, maintains the tissue structure and barrier function of the gastrin mucosa, and reduces translocation of intestinal bacteria and endotoxin. It buffers acidity in the stomach, reduces reverse diffusion of hydrogen ions into the mucosa, and reduces the incidence of stress ulcers. Part 4. Dynamic or burn shock prevention and treatment. The first is to alleviate fluid loss and reduce the body's demand for liquid infusion. The second is to improve the oral liquid infusion scheme, expand its scope of use and reduce dependence on intravenous liquid infusion. The third is to improve the intravenous liquid infusion scheme and reduce the intravenous liquid infusion volume. The fourth is to improve the body's tolerance to shock and mitigate the harm thereof. That's all for today. Thank you.